Okay, in the interest of time, let's go ahead and get started. Dr. George, if you'd like to give yourself an introduction, and then Dr. Kasim is going to help moderate the meeting. So, Dr. George, go ahead and get started, please. Thank you.
Okay. Hello, everybody. Good afternoon. I hope you can see my screen. I started sharing. My name is Vanetta George, and I'm a consultant general surgeon at the Sir Leicester Bird Medical Center in Antigua. For those who don't know about Antigua, we're a small island in the center of the Caribbean, just with a population just about 100,000. And so I brought this case which generates some interest in working in a low resource setting. And it's a thoracoabdominal gunshot wound. And how do we make decisions when we don't have all the things we need? So let's see. Good. I have no disclosures. I'll use the mouse. And we're going to discuss a bit about imaging and penetrating thoracoabdominal trauma, review the post-op management or options for penetrating liver injuries, and have a short discussion, I hope, that could guide decision-making in low resource centers. So I have a 19-year-old patient who was brought to the ER via ambulance with a single gunshot wound that went through the left chest wall and the exit wound at the right chest wall. There's more information on this case. He's brought in by paramedics who reported that during transport, this patient was very combative, came in with severe respiratory distress, hypoxic during transport, hypotensive, and they took just about, since the incident to arrival in ER was just about 45 minutes. His airway seemed patent. His chest expansion was asymmetrical, more so decreased on the right side. The breath sounds were decreased bilaterally. You could see the gunshot wounds that I explained. They were on the left chest wall and right chest wall. He was tachypnic, oxygen saturation below 90%, and he was on a non-rebreather face mask. His blood pressures were low, 90/60, tachycardic at 130, pale, cold, and clammy. The patient was here in shock. And what would you think would be the best thing that we could do next?
Great case. Now, I like to divide this into two parts. So first part would be, he is combative in the ambulance ride. Is there anything that we can do to address that while he is being transported, Dr. Untrak?
Well, yes, combative for several good reasons. First of all, it may have been his pre-existing status, if he would, if he had alcohol to drink or whatever, or if not, likely it's because of his dyspnea and his shock state. So I think the first thing to address would be, breathing, circulation, and airway. And the paramedics can deal with that. It's obviously bilateral chest wounds and reduced breath sounds. So the paramedics can do, a finger thoracostomy if that's part of their training, or bilateral decompressions, at the mid-axillary line bilaterally. But they can do chest tubes if that's allowed for them in Antigua, fine. But I think they need to do something to address that. And the cutting edge now is pre-hospital transfusion. They carry, the packed red blood cells. They can start to transfuse that. But otherwise, they need to address those points and then get them to the hospital, and then proceed with the appropriate resuscitation there, which means in the OR for this patient.
Actually, I was looking for any. Those are all, by and large, not available in many institutions, and I'm sure Dr. George will tell us that it probably is not available in the ambulance as well. But I was looking for pharmacologically, is there anything we can do? Dr. Hartman, what do you think? What do you think?
Um, I so this patient is agitated and hypoxic, and there are two main reasons. One, it could have a respiratory distress. It has bilateral gunshot wounds, so probably bilateral pneumothorax, or two, might be bleeding, and that is causing decrease of cardiac output, and the patients experience usually when that happens severe anxiety and become very agitated. It all depends on the resources you have. Here it's very common that the patients will, something like this, they will start on ketamine, or I hope not, but it could happen that they will intubate. I had a patient like 2 years ago when she had a stab wound to the chest and she was agitated, and the paramedics decided to intubate her because she was agitated, and she arrested. And eventually they brought her providing CPR, and she had a laceration, a stab wound to the left ventricle. So that's the reason she was agitated. So the best thing they can do for those patients is to put in the ambulance and come as fast as, if there is a hospital close by, bring the patient as far as you can to the hospital and address the issues there. Otherwise, you can try, as Dr. Unter said, try to do bilateral finger thoracoscopy. That here the ambulances are not allowed. The medics in the helicopters are allowed. So that varies from region to region, and maybe give volume. But there is really not too much that you can do in the route. You can use Precedex, but we don't have those in the ambulances here.
Dr. Frisbee, what do you think?
I think Dr. Hoyman's got it. I would hesitate to give any pharmaceuticals to somebody who is 90 over 60, agitated. He's going to drop like a rock. You're going to lose everything. So just put his behind in the ambulance and get him there as rapidly as you can. And I would not try to entertain intubating him in a moving ambulance. You may be successful, you may not. But once he hits the door, he's going to need bilateral chest tubes and a lot of resuscitation. And then under controlled conditions, you can intubate him. But I would not do anything like that in the ambulance.
Dr.
Very
Frey,
good.
sorry, Dr. Frey has some comments here.
Hi.
Go ahead.
I have a question to Dr. George. Do you think it was only one bullet? You have entrance and exit of the wound, or maybe two bullets because you have in the right and the left?
This was just one bullet. One bullet. And it was said that they heard one gunshot, and this is one bullet. And they described it as entry to the left and exiting on the right side.
So that will make it a transthoracic injury. Now, Dr. Untrag, would you like to tell us what steps you will take in the trauma bay?
Did you just call on me?
Yes, I did.
Yeah, so he's 45 minutes away, so that's a long time for somebody that's in stage 3 shock and agitated. You would hope to do something to maybe ameliorate a little bit so he survives the 45 minutes. I think the best thing you can do is proper decompression by the paramedics, and most can usually do that. And I assume that in Antigua, they're probably all very smart, and they can probably do that there if they have the equipment. But once he gets in, you need to trigger the massive transfusion protocol. This wound, if a straight line between the entry and exit points, it would either have crossed in the under the aortopulmonary window, or inferiorly, just missing the aorta and the heart. But that's really, another great shot. And we only see the great shots here because the others never make it to the hospital. But he needs the IVs, start to transfuse blood, decompress both chests, and see if that stabilizes him. Then you really need to get to the OR. If he gets stable, you put 2 chest tubes in and you give him some blood, and he's a robust responder, and he remains stable. Then, because of the potential trajectories of the bullet, if you can do a CT or CTA of the chest with contrast to help you really fix any serious injury that might be fatal, I would do that. Otherwise, I'd go to the OR, and then it's a matter of what incision to make. And if you don't know where the injury is and you need good access, you need to be able to access the posterior mediastinum, really, because that's likely where the injury is going to be, and it depends on which side is best. So I don't know if a clamshell incision would give you that access, or if you knew exactly what side the injury was on, where you needed to do the repair, you do the appropriate either right or left posterolateral thoracotomy. But that's a tough one. So it all depends on how he responds initially to the initial resuscitation attempts.
Dr. Fraga, would you like to say something?
Just a comment. I think you have different systems of a pre-hospital in different countries. Like in Brazil, you have the basic life support. They cannot put a thoracostomy. They cannot just EV line and go to the hospital. And there's a advanced life support, like the pre-hospital in France, Europe, SAMU. So where you have the physician. So the physician, he can put a chest tube at the scene, at the ambulance. But I think this patient needs to go to the hospital as soon as possible. Have the patient go direct to a trauma center, a hospital where they can have a treatment, a complete treatment, because it's a critical case. It's a transfixing injury. The patient is unstable. So you need to go to the hospital as soon as possible. This is my comments.
Dr. Hartman, this is a transthoracic thoracic injury, like I see it. So what would you do?
Okay, I'm sorry, I was a little bit distracted. I thought there were 2 gunshot wounds, one in this
No,
side.
it's only one.
It's only one. So this is the main concern that you have here is a transmediastinal gunshot wound.
Right.
Could be also because this is, and I saw the title is a thoracoabdominal. It could have been that went below the diaphragm or nicked the diaphragm, and doesn't have too many intrathoracic injuries, and the injuries are mostly in the abdomen, which would be great if you have 45-minute transfer. So, but assuming that the injuries are limited to the chest, and you are in the field, there is not too much you can do. You can put bilateral decompressions, either with needle or finger or whatever, that would be great. But doing bilateral decompressions, you need to be ready to intubate because the patient will not be able to breathe because the lungs will collapse. So that's a problem if you cannot intubate. And I will give volume because the other thing I'm concerned is this patient bleeding. Maybe if the heart was nicked, I had a patient once like that, exactly like that. The bullet went just under the heart and caused a small laceration and presented with tamponade. The way that you can buy yourself time with a tamponade is to administer fluid to increase the central venous pressure because the ventricle collapses when the pressure outside the ventricle is higher than the pressure inside the ventricle. So that will buy you time until you get to definitive care. But this patient needs to get to the emergency room and be sorted out there. There is really not too much. There is no austere or full of resources environment. This patient needs to go to the operating room, to the emergency room as soon as possible. So I don't think it's too much of a difference depending on the resources you have. You have to bring this patient quickly.
Dr. Frisbee, Dr. Hartman made a very good point that this could be involving below the diaphragm as well. So
Certainly could. And everybody knows that the things that are going to kill you are below the diaphragm, not above them. Otherwise, you won't make it to the OR or the ER. But the very
Right.
first thing, one of the very first things I would do is see if I couldn't get a portable chest X-ray. It'll give you something to go on
Yes.
before you start all this stuff. You're going to have to be doing several things at one time, and one of them has to be, if you can do it quickly, is just shoot a chest X-ray. It might give you the path of the bullet, and you may or may not benefit from that, but that's one of the things I would do. Of course, you're going to have to secure the airway, and you're going to have to put two bilateral chest tubes in there, and as Dr. Hoyman said, you're going to have to load him with fluid because I think he's going to drop pretty quick, and of course get him ready to go to the OR just about as quickly as you can.
I think along with the chest X-ray, if it is available, I would also add a quick fast examination to see if there's fluid around the pericardium, if there's fluid around in the infradiaphragmatic area, which will also give you a clue that either he's bleeding above the diaphragm or below the diaphragm to help you to make a decision. Okay, Dr. George, go ahead.
Okay, so well, we did resuscitate this patient. Luckily, the surgeons, we were 2 minutes away from the ER when this patient arrived, and the emergency medicine consultants were also present. So he was quickly intubated. We placed bilateral chest tubes. There's no massive transfusion protocol, and there's no blood available in our ER, and there wasn't any fast available. So this is this patient, chest tubes, and we decided to do a quick X-ray for him, and this is what we saw.
I don't know, the portable X-ray.
Dr. Hodgman, would you like to comment?
Sure. He obviously he has a hemothorax on the right.
Right.
I don't know if it was any rush of air when the left side the chest tube was placed in. Okay, so he has a pneumothorax. So we put the chest tube and see what happens, if the bleeding continues or not. If it would be on the left, it would be easier. On the right, the bleeding could be also, we were talking about thoracoabdominals, it could be from the liver. And frequently when we get massive hemothorax in this type of cases, the bleeding is more from the liver than from the chest, but we still don't know. So the question is if this patient is going to the operating room, when and where, which approach you will use. If the patient is stabilized at the chest tube, can we do any more imaging? Definitely, as Dr. Kasim said, this patient needs a fast. Oh, you don't have fast, sorry.
No fast, but we have CT available.
Is the patient is not very stable. So this patient, with the limited information I can gather, okay, so I was thinking, what it can be the worst thing? He has a gunshot wound that went through and through in the chest from right to left or left to right. The thing I'm concerned here is what happened to the heart, and I don't have a fast. So I will take this patient to the OR and do a subxipho-pericardial window and start there. Meanwhile, I see what will continue to happen with the left side of the chest. And the subxipho window is negative, I will consider doing a right thoracotomy to see what is if the bleeding continue. So really you don't have too many options here, or consider doing a laparotomy. Those are the two options, really.
Dr. Fraga, what would you do, sir?
Yes. Can you go to the X-ray? Go back to the X-ray. So the X-ray is what you have available. You don't have blood in the hospital? No blood in the hospital?
Well, the blood, we group and cross match blood, but the blood is not ready for the next half an hour.
Half an hour. Okay. And you don't have another image, CT, you don't have in your hospital?
Yes, we have CT.
Okay. I think the mediastinal, I think there's the mediastinal, some suspicion there. You can observe in the X-ray on the left is okay, but you have a retaining pneumothorax on the right, and the pericardial window. If you go with the patient to the OR, maybe start with a pericardial window. I don't know if there's air in the pericardium. Looks like there's air in the pericardium. I think there's air in the pericardium. So start with the pericardial window. That's what you keep this patient to die in the next minutes if he has a cardiac injury. So I start with, you can do a subxiphoid pericardial window before have the decision. Because you don't have fast, you cannot look in the abdomen. But the problem is the chest. I suggest you start with pericardial window.
Very good. Dr. Frisbee, tell us what you would do, sir.
Well, I'm looking at the X-ray, and I think Fraga's right. I think that that bullet has passed through some of the pericardium. Whether it has done any injury to the heart, we won't be able to tell. But it's awfully cloudy on the right side, so it may have gone below the diaphragm and then back up and out the chest cavity. At this point, a window is probably appropriate.
Okay, as the moderator, I would like to contribute as well. So when I look at this, when I look at the chest X-ray, I ask the same question. What is the single most important thing that I'm looking at that could kill the patient? So my answer is most likely, injury to the heart is going to kill the patient because he's going to have fluid accumulate in the pericardium, which is going to get larger and larger, and then he will arrest. So I agree with all of you, the people who have said that they will go for pericardial window. I think I would do the same thing. I would look at the pericardial window to make sure that I'm not overlooking something that has accumulated in the pericardium that I may have to go after it, because that is the thing that's going to kill the patient very quickly. Dr. Untrak, I didn't ask you what you would do. Please contribute.
Right. I think that is reasonable. Although you're really in a bad situation in a resource-poor location. If you take the patient to the OR and do pericardial window and the heart shadow, it doesn't look dilated. It looks like it's normal size. But if you put the patient to sleep and then do the pericardial window and don't find anything, now the patient might be severely hypotensive. So, you have to try and think about what to do with resource limited locations. So you say the blood's going to take half an hour. Fine, you don't have fast, but you probably have an ultrasound tech in the hospital with a machine that they can roll to the ER. And if the patient is too unstable to take the CAT scan, you can ask, and your hospital probably it's, for 100,000 population, it's not a big sprawling place, and they can probably get the ultrasound, wheel it down in 5 or 10 minutes, and bring it down, and then look at the heart. See if you have, so you don't invest resources in doing a subxiphoid pericardial window for a patient that ultimately doesn't have anything to correct there. So what I would do, I'd give her tranexamic acid if you have it. You might not have it, and then call the ultrasound tech down, and I would do damage control resuscitation. So avoid giving too much volume other than blood initially. So give your 1 liter of fluid of crystalloid, and then wait for the blood to come down. Don't try to raise the blood pressure above where it is now. And once the blood comes, then by all means give the volume, but not too much until you know what needs to be corrected in the OR. And then also this, Dr. Hoyman's point is excellent. A trajectory that goes from the 6th to the 10th intercostal space on the right and didn't go through the aorta and the heart would have to have passed through the dome of the liver. So the diaphragm, the liver, and then, in and out through the diaphragm, the dome of the diaphragm, and then out the 10th interspace, which is, just above the floating ribs at the mid-axillary line. So that's where there's going to be bleeding. So I think in this case, probably the best way, given the patient's condition, is get the sonographer down there, assuming you have ultrasound in your hospital, Dr. George, right? You have ultrasound?
Yes, the techs are on call.
Yeah, okay. Hey, call them
You have
down.
to call them out.
Yeah, they're on. Oh, you have to call them
That's
into
an
the hospital.
hour.
You have to call them to the hospital?
Yes, that's an hour.
Oh, geez. Well, I might have done that when the patient was on the way,
Okay.
especially after this case, knowing that, look, that's what you have to do. I was in a hospital in West Africa where they had a beautiful GE ultrasound machine, but no portable machine. So I'd have to get a key, run across the other side of the, this tropical hospital, and open the door and get this machine and wheel it down to the ER to do that. But you want to try to do that while the patient's en route, if the patient's on the way, and then have a look, because that's, as everyone was saying, you need to know exactly where the problem is, where you need to intervene. If it's in and out through the liver, and it didn't get the vena cava, unlikely, that kind of a bleeding, if that's really where the bleeding is, you could stop it by opening and packing and all that. But you're really in a touchy situation where you have to, lack of resources, what you have, how can you leverage what you have to get the right information? If you can go to CT, and that's the quickest way, and you go with the patient and you're able to intervene if his condition deteriorates, fine. But at this point, you have the 2 chest tubes, it's not pouring out blood, he's still hypotensive, you need to buy time till the blood gets there, and fine, I think it's okay to go get a CT or the ultrasound, whichever's quickest.
But
So-
Untrach, he's very hypotensive to go to the CT scan.
No, I wouldn't. Not at. Well, what is it now? Was it 100 or 60?
It was 100.
It was
over
90. It was 90.
So
And then it was 100.
No, heart
Yeah.
rate 145. Yeah, that's a tough situation. But damage control resuscitation, you want to aim, as you know, for systolic of 90. And then when the blood comes, okay, give him some volume, not raise his blood pressure too much until you know what the diagnosis is. But yeah, I agree. You're in a tough situation. If you're just waiting for blood to come or the ultrasound tech to come, whatever, if you're going to do that, well, whatever, is it better to wait on the CT scan table? You can do just as much there as the ER, or just go to the OR. Take your best guess. You can do a laparotomy and then look at the pericardium at the same time. Open the pericardium, and if there's no blood there, then open the belly, look in there, and pack the liver. I think that's reasonable at this stage. If you have 700 cc's of blood out the right chest, no more, and the patient's still hypotensive, if the chest tubes are functioning and you're not pouring out blood, then you have to take your best guess. And I think it'd be reasonable to go into the belly, look at the pericardium at the same time, and start to give the blood once it's available.
Dr. Fraga, please tell us what you would do. 1, 2, 3. Tell us what you do first.
I think CT is very important, but this case, I think I go to upper triathlon, start with a pericardial window, because
Okay.
you lose time. I think the patient is unstable, I think you go to operative room.
And the window, the pericardial window is negative. Then where you go from there?
Look at the chest, the depth output. If you increase on the right, you have is 700 milliliters. If you have more blood coming, maybe start with a right thoracotomy and think about laparotomy later. But I think this precardial window will be positive.
Okay. Dr. Hartman, could you tell us what you would do?
Yeah, the pericardial. I have to say, we are getting spoiled here in the States, or even in places like Sao Paulo or Rio, that you have all the resources. But many years ago, I was working in very poor hospitals. We didn't have anything, not even X-rays sometimes. So I totally understand that you are doing the best you can with the resources you have. So if you don't have ultrasound technician in place, or the technician will tell you, oh, I don't do a hard window, I just only do abdomen, because that happens, you have no option but to do a pericardial window. That would be the first thing to go. And go from there. Pericardial window is positive, you go median sternotomy and you go from there. Pericardial window is negative, um, you can do both ways. You can do a mini laparotomy that is blood in the abdomen. I will go to the abdomen because we worry about the liver. Liver usually bleeds more than the lung. If the mini laparotomy is negative, I will open the right chest. And the only reason I'm reluctant to go straight to the right chest is because I got burned before, that the bleeding is coming from under the diaphragm more frequently than the chest.
Thank you. Very good. Dr. Frisbee,
Yeah,
tell us what you would do.
I think if it keeps pouring, especially on the left side, was it the left side, right side?
Right side.
Yeah, if it keeps pouring on the right side, I think I would do a mini lap, because if it keeps pouring, it's probably coming straight from the liver across the defect in the diaphragm and
Yeah, sorry. No, I was going to add one more thing, Dr. Phoebe. We usually, the most common thing that we see with hard wounds is a pericardial tamponade, but sometimes, and the reason for that is the pericardial tamponade, although it's really bad physiologically, usually they give patient time to get to the hospital. When you have a free rupture of the pericardium into one of the pleural spaces, usually the patient exsanguinates before he gets to the hospital. But that's also possible. It could be that the wound is in the heart, bleeding into the right pleural space. Less likely, but that's a possibility to consider.
All right. So, Dr. George, would you like to continue? Tell us what you did.
We have to rush him somewhere, and
Yeah.
so we rushed him to the operating theater for XLAP. And I thought that if first I'd go, I'm a general surgeon, so first it's quicker for me to do an XLAP than a thoracotomy. And so I thought, let me do an XLAP because I'm gonna review to look for hemopericardium and look for hemoperitoneum first, and we'll see. And the blood, he's in theater, but the blood has not yet arrived. Right?
Right.
So, yes, entering the abdomen, midline, incision, I have a 3-liter hemoperitoneum. There's a diaphragmatic wound just below the heart to the right side, which is about 2 centimeters, 2 by 2 bullet wound. We could see that there was a hemopericardium. So it was about 20 cc's. And there was a liver hematoma that was felt towards segment 2. The capsule of the liver was very intact. And then there was a wound, which have been the exit to the liver around segment 6. And it seemed that the liver was stable. And so that's what we found. And what would you do now?
Tell us one more time what you found when you opened the pericardium.
blood.
There was
So
blood in the pericardium. There was
blood in
only
the
20
pericardium,
cc.
and reviewed the heart. The heart did not have a structural injury.
Okay.
Right. And then there was about 3 liters of blood in the abdomen.
Right.
There was a diaphragmatic wound towards the right side of the diaphragm, and a big hematoma in the liver. Well, a hematoma in the liver, more the left lobe, that was felt first.
Dr. Frisbee, now you were the surgeon in the operating room. You saw all these injuries. Tell us what you'll do, sir.
Well, you got some blood in the pericardium, so open the pericardium, let it drain, see if you've got an injury in the right atria or on the right side. If you don't, I would pay attention then to the liver hematoma, and you're going to have to, since it's bleeding actively, you're going to have to explore that. Heavens to Betsy, that hematoma of the liver, and you're going to have to pack it until you can get at least some idea as to where the bleeding's coming from. If it's coming from the inferior vena cava, that's one thing, but if it's just coming from the parenchyma, that should respond to some packing. That's what I would do the next.
Dr. Unchak.
Yes. So, you've you already opened the heart, 20 mLs of blood. That's okay. It's open. So this unlikely to suffer tamponade going forward. And really the bleeding, and you made the right call, because 3 liters, that's where most of the blood was after the gunshot. And we haven't seen what the wound looks like. The segment 2 wound looks like it's contained. There's active bleeding, apparently with not an intact capsule in segment 6. If it's a big open wound that you can see into, go ahead and pack it. I'd try the Pringle maneuver, see if it stops the bleeding, whether the bleeding's venous or arterial based on its appearance. If it stops with Pringle maneuver, then you know what you have. You can keep the porta clamped for a few minutes until you can catch up with the blood, which should be there soon, while you have the porta hepatis clamped, and then look at the wound, try and find any major bleeding vessels, clip those off. Otherwise, just pack the wound and start transfusing the patient when the blood arrives, and let the anesthesiologist catch up with the blood loss. But that seems to be the source of the shock and hypotensive, segment 6. So you need to focus your attention on that.
Dr. Fraga, what did you do, sir?
As I can understand, the entrance was through the diaphragm on the chest, right lung, left, right lung, diaphragm, and segment 6 of the liver, like a liver transfixing injury. Do you think, or from 2 to 6? Do you think was the transfixing from 2 to 6 because the injury was in the right diaphragm, correct? The right side.
Yeah.
Right.
That's correct.
Correct. Okay. And about this bleeding in the pericardium, it was active bleeding. Did you watch? You need to tamponate the liver when you need to have the decision about there was or not a cardiac injury. Was active bleeding coming from the heart or no? Not active bleeding.
The heart was not actively bleeding. There was no bleeding from the heart.
No bleeding. So maybe a grade 1 injury, only the pericardium, maybe.
Right.
So if you are very confident that's no cardiac injury, I think you need to treat the liver. At this time, you have 3 liters of blood. You need blood for the anesthetist, stop the surgery, control, it's a damage control surgery. You need to give blood to your patients, resuscitate the patient to have the best decision for the patient. If it's possible to control this active bleeding, you can try to approach the liver and make suture. But if you can control with only packing, maybe you can stop packing the liver and resuscitate the patient to have the next decision later, like a damage control surgery. And just observe the hurt. Thank you.
Dr. Husman? Dr. Husman.
So I would do things a little bit different, and it doesn't mean that anything that was say here is anything wrong with it. It's just I just do the things a little bit different. I will do the pericardial window before opening the peritoneum, and because that's the injury I'm more worried about. And the moment I open the peritoneum with 3 liters of blood in the abdomen, that will distract all of us trying to control that. So I will open the pericardium. I usually do the pericardial windows by going extra peritoneal, doing the pericardial window. And if the pericardial window is positive, I am too old-fashioned. I would probably, particularly in a patient who's hemodynamically unstable, I would do the median sternotomy. I know that some people argue, and some people much wiser than me, like Dr. Ginsburg, that you can put a drain, make sure it doesn't bleed, put a drain, and see what happens, and they're usually fine. However, I have a patient who's hemodynamically unstable. I am concerned about other injuries. I just want to rule out that there is nothing going on there. It could be an injury to the right atrium. Intermittently they don't bleed, and the patient suddenly cough and start bleeding again. So I will do a median sternotomy. There is nothing there, I will go to the abdomen. And when I go to the abdomen is what I'm going to do with these liver injuries. Dr. Umtrach said clearly, first thing we should do is a Pringle maneuver. If the Pringle maneuver stops the bleeding, we know that it's either the portal vein or the hepatic artery, and the hepatic veins are mostly intact. If the bleeding continues, we have a problem. The other thing I will tell anesthesia here, and this is very important, is to keep the central venous pressure low. And this is something that we need to fight with anesthesia when we do this, because they want to resuscitate in case it has a massive bleeding. But the liver from the bleeding, you want to keep a CVP less than 5 millimeters of mercury, because in that case, you don't have usually back bleed from the IVC into the hepatic veins. That's a trick that I learned from the liver surgeons. So, and after that, I mobilize the liver, taking down all the falciform, the triangular ligaments in both sides, and pack it and see what happens. If the bleeding stops with packing, great. If not, I might have to put a few chromic sutures to control the bleeding. And we have cases where we have like this, that the bleeding is poorly controlled with packing. We pack and we move the patient to the hybrid operating room, and we have radiology come in and embolize the liver. And after that, we remove the packing while the patient still is in the operating room to see what happened. That would be my approach. At this time, I think that the bleeding in the chest came all from the abdomen until proven otherwise. Thank you.
Well, thank you, Dr. Husman. This is what I would do. I would I would do an extraperitoneal pericardial window. Before I do that, I have a good look at the peritoneum in the peritoneal cavity, because it will tell me what is underneath that peritoneal layer. And I will make a note of it. Open the pericardium, and if I saw only 20 cc of blood, I will call it quits. I usually would put a drain over there in the back of the heart, and then I make my attention, pay my attention to the peritoneal cavity. And in the peritoneal cavity, the first thing I would do, like Dr. Untrack said, I would clamp the portal trioid and then look to see if I can either suture or pack the area that is bleeding. I would leave the hematoma alone. I would not do anything. And at the same time, I probably would not do anything to the diaphragmatic injury as well if there's a hole in the diaphragm. And I would allow the anesthesiologist to catch up but at the same time, not to overwhelm the patient with fluid. And then I will leave the packing in the area. I'm hoping by now I have stopped the bleeding in the liver and close the abdomen temporarily with a view to looking back within 24 to 48 hours. That's what I would do. Dr. George, tell us what you did.
I did the window first, but I did a pericardial window because I was already in the abdomen. And after doing the window and aspirating the hemoperitoneum, I started to packed around the liver for a while to wait and see what was happening. It settled down. I waited until we got 3 units of blood and plasma, and the patient seemed stable enough on the table. So at that point in time, I just put a stitch in the area that was bleeding at the around the segment 2 that was bleeding a bit more than the other wound. I just put 1 stitch there and it stopped. Closed the hole in the diaphragm and waited a bit. I think what we didn't do here, I did not packing. After I took out these packs, everything stayed dry. Blood pressure is good on the table. Heart rate is good. And we had the blood. I said, well, let's close him and see what's going to happen. So here, I was going to say to drain after the end of surgery, the right side, as you thought, might have been more what was coming from the belly. And so that wasn't all blood anymore. It was a bit serous sanguinous after we washed. The left side did not increase in terms of the amount of blood. It was just about 50 cc's more after surgery. Patient seemed stable. And so I closed, and I think because in the interest of time, because it's a little longer, I'll go. I take this patient to the ICU. I got 2 more units of blood for him. I had some challenges getting him a CT on the first day, and so he got a CT the next day. And this is, I think here, I tried to put the slides to see you could see the progression of the injury that he had. If you can see coming through the liver. Here, coming. I think I should have, let me see this. I think you can see it better here. He still had some blood on the, right?
Oh yeah.
Mm.
It
Oh, yeah.
seemed like this liver was completely transected. Let me see if I can get it to go and stop. Here, let's see. Not, oh dear, 1 second. Let's see if it comes better.
Oh yeah. There we are.
Yeah. So, what do I do with this patient now?
So what you showed us was the left lobe of the liver is completely transected from the right lobe. Am I right?
The entire liver is, let's see if I get an image. Let me see. Maybe this one. Let's see. Stop it at. You see it completely across.
There. Okay, it's going across. Okay.
Yes.
But there is viable liver tissue still available at the top of the
Yes.
liver.
Yes.
Right. So you have a significant injury to right and left lobe of the liver. And this is day what? What day was this?
Day 2.
Day 2. And is he hemodynamically stable?
He is stable in the ICU.
Is he on any vasopressors?
None.
None.
Mhm. Yes.
Dr.
So,
Untrack, tell
yes.
us what you'll do.
Yes. So, well, right now is a little tachycardic, 110, and blood pressure is great. I assume he's making urine. His chemistries are all fine. Lactic acid, if you have it, is probably normal. His O2 sat is near 100%. So I think you've done good. It would have been less nerve-wracking had you had blood earlier. But in this case, both is a big cleft through the liver in the direction of the bullet trajectory, but the liver on both sides of that cleft is well perfused. So what I would do is follow him. I would expect him maybe to get septic in a few days, start to show signs of infection. And yeah, what I would do there is got a big hematoma in the posterior segments of the right lobe, and then the bullet tract that goes through out the left lobe, or from the left lobe. Yeah, right there. But you see this good perfusion of the parenchyma of the liver, both sides. So I would just follow him, and then if he starts to show signs of sepsis, you probably don't have interventional radiology. And even if you did, I'm not sure if that would be the best thing in this case. I would take him back and just debride that wound, take out all the infected material, all the blood clots, free up a pedicle of omentum, pack it in there, and be sure that the hemostasis should be good at that point. It's just going to be a matter of hematoma, possibly with infection. But I would do that, and then if you saw clearly necrotic liver, you would debride that also. But I would think that most of the parenchyma on both sides of the injury, the wound, are viable. Both sides, the parenchyma is okay. So, but that's what I would do. You're winning here, so I think you're on the right track.
Dr. Hodgman, tell us what you'll do, sir.
We am too irresponsible. We didn't do anything.
There you are.
That's
not a bad deal.
Yeah.
Dr. Fraga, what did you do, sir?
Now I think you need to wait. Just follow the patient.
Yeah.
The patient is stable. Follow the patient. I probably put a drain in the abdomen when you have a grade 3 or 4 liver injury. Usually put a drain in the abdomen, but it's not a problem. Don't have the drain. Just observe and pray.
Dr. Frisbee.
Yeah, prayer's
Dr.
good. Prayer's very good. And to tell you the truth, I can't see an issue until he develops one. At this point, I just watch him.
Okay.
Well, I agree with Dr. Hodgman. Don't poke the liver. Don't poke the bear. Leave it alone for the time being. He's not telling you anything different than what it was, say, several hours ago. But, time will tell whether he needs something done. Perhaps not. Maybe he will recover. Maybe he will develop an abscess in the liver. And at that time, you may have to deal with it. But for the time being, I would do nothing. I would just watch him. Tell us what you did, Dr. George.
I watched him. I watched him.
There you go.
I watched him, and I eventually got the blood that he needed. He stayed stable. Chest tubes were stable. Digestive tract came on board. I started feeding him. He was still intubated. And on day 5, now, when they were tightening him, he has some increased subcutaneous emphysema on the right side and air leak. So I had to put a new chest tube for him there. And then In the interest of time, sorry, I was just going. We followed his liver function tests. So his white cell count didn't go over 16,000. It was 15,000. The only elevated liver function tests were his GGT and his ALK-phos. Those were the only things that were elevated. And he was able to get out of the ICU by day 12. And I embedded the ultrasound. Now on the ward, I said, he's fine, but I'm still concerned that something could be happening, although clinically he is fine. I said, let's do an ultrasound before he leaves. Let's see if I embedded the images properly. Let me see. Liver. Can we see that? Wait, let me pause. Wait.
Yeah, yeah, we
Go back.
can.
Right. So this liver lesion stayed very stable there. And so I decided that with his liver function test getting better, GGT is coming down, alpha's coming down, he was able to go home. And now I'm concerned, how am I going to follow this patient? That was my major concern. What am I going to do now? What else do I do with him? Is there anything else to do with him? So I set up what would you guys do?
Dr. Frisbee, let's just start with you.
Well, what would we do? He's 19. Is he going to come back to follow up? Or is he just going to blow it off? I mean,
he's going to come back.
Oh, he's going to come back. Okay. Well, you can repeat his functions and his lab functions, and you can also repeat his ultrasound to see if that cavity is coalescing a little bit, and if his white count stays down and his enzymes are coming back towards normal, I think you've done what you're supposed to do. That's all I've got.
Dr. Osman.
I'm sorry, I am on call. I'm a little bit distracted. I am very. I wouldn't do anything else. And some of my partners do a CT scan in a few weeks. I don't. Why? Because if I do a CT scan and I see something and the patient is totally asymptomatic, I probably will not do anything. So why do the CT scan? If the patient is symptomatic, yeah, I will do a CT scan. But most of those patients, they're totally asymptomatic and they heal and nothing else needs to be done. In all my years in practice, I have only one delay bleeding from the liver. And it happened when the patient was still in the hospital. So it's extremely unusual to have a complication like that. Some patients like this might develop hemophilia, but they will present to the hospital when they have the bleeding and the pain and everything. So I would just wait. I will not do anything with the imaging unless the patient has symptoms. So that would be my approach.
Dr. Fraga.
Yes, the patient is asymptomatic, you just can observe, but usually grade 4 liver injury, you prepare a CT after 3 or 4 months after discharge. This is our protocol. Maybe you can change the protocol in the future, but probably you have a CT later, 3 or 4 months after the injury.
Dr. Untrack.
Yeah. So I agree. Just following the patient, and about the CAT scan, the only reason to do it is if let's say he does develop a big cyst or a mass there, and then he comes back in a year or 2 years with some acute problem. It'd be nice to have a baseline to know that, okay, well, you would do a CT, and when he came back in 2 years symptomatically, and then you see this change, and then you don't know if it's acute or it's just from the old injury. So I would do it just for one time, if he's doing well and he's asymptomatic, just for a baseline. But I agree, just follow them. You've won here. So then, good. You use the limited resources but the one unlimited resource you have is your cognitive skills. So you made the right guess. It was the right hunch. And all I would do is, you're the boss. You got that MHA degree and all that. I would say, look, we need to have get a refurbished sonosite for cheap that works great. And then you teach everybody how to use it, and you have it. It's like your personal thing down in the ER. You take it out, you have a look, and that would have been right here in the ER. If you had that, you would have seen a big hemoperitoneum initially and wouldn't have wasted. You wouldn't have had to say, okay, what should we do now while we're waiting for blood? You would have gone right to the OR, done the laparotomy. You would have seen minimal hemopericardium, but I think you need that at least. That's the one thing to have if you have nothing else.
Well, we do have it now.
Okay, there you go. So you got it after this case. Very good. Well done. And then use it all the time. Even anyone that you examine the belly just to get a lot of experience.
Dr. George, I think I take it in Antigua you have British training, right? Most of the surgeons follow the model of the British training. The reason I'm saying that is I trained in Britain, and we were taught to look at the patient before sending him to any test. And if that's how we were trained in Britain. And so I will follow that theory. Keep watching the patient and look at the patient to see what he's telling you. And then you decide if he needs any CT scan or any other test. By the way, we overuse CT scans enormously in this country. And I don't know what's going to happen in the next 10, 15, 20 years. We probably will have a whole bunch of cancer-related patients because CTs. And be as it may, I think you have done a fantastic job on this case. And now I think if I ever come to Antigua and if I get shot, I will look for you to take care of me.
No, you will not get shot, but please come to Antigua.
Dr. George is the only one to take care of you there, right? There you go.
No, there are other people.
And I'm surprised Antigua people get shot there. I wouldn't have expected that.
Yeah, I think it is unusual to get shot in the Caribbean, except in St. Croix. I think there's a gang in St. Croix, and I think they keep shooting people. I don't know why. But fabulous case, very educational. And I learned a lot. I'm hoping my colleagues learned a lot as well. And we thank you for presenting a fantastic case. Thank you.
Thank you.
Okay. What's that?
Oh, Dr. Fraga has something to show us.
There's a gift. There's a gift to Dr. Jorge.
Oh, what is this?
Oh, wonderful.
Peanuts.
Okay, for everyone interested, I put the CME information in the chat. Oh, nice hat, Dr. Hoffman.
Argentina.
Messi. Very
So yeah, no, Dr. George, seriously, you show, we have all the technology here. Sometimes we thought, I will do this, I will do that. It's embarrassing. And you prove that the most important thing for the patient is to have a surgeon with a brain and two good hands. And that just makes the whole difference. All the technology would not change anything. But those three things are really very important.
Okay, thank you. Thanks for having me.
Sure.
Pleasure.
Okay.
Thank you, Kevin.
Thank you for moderating, Dr. Kasim. And thank you, everyone, for being here. And Dr. George, thank you very much for a very interesting case. Have a great rest of your week, everybody.
You did a great job,
Thank
Dr.
you.
George.
Okay.
You two guys look like you're 20 again.
Yeah, I was expecting the first to come here earlier so we could talk. I'm covering the ICU today, and I'm kind of like that. I got like 20 texts meanwhile while I was sitting here, so totally distracted. Sorry.
Yeah, you're both looking really young. Every time I see you, you get better.
Yeah, sure.
It's
You
true.
you need new glasses, Dr. Frisbee.
Oh gosh. Well, listen, have a great week. I hope you have
Hey,
a great visit, Dr. Fraga.
yeah. So okay.
All
Okay,
right.
and Francisco Collet there too.
Francisco Collet is there.
Yeah.
Francisco is
Yeah,
there.
we met at the meeting 2 years ago.
He came here.
No, we met in Chicago.
Chicago.
Chicago, yeah. Oh yes, and we also here in Boston. Yeah, one in Boston too. He presented in Boston.
Yes, we need to organize a meeting someplace, maybe here, United States or Brazil, come together to the same place to have a barbecue. I think it's important. Chorizo from Argentina. Prepare barbecue.
It's the same competition that you have in soccer, you have also for the barbecue between Argentina
Yes.
and Brazilian.
They have a good barbecue.
Obrigado, huh?
Okay. Bye, guys.
Bye bye.
Bye. We'll see you.